Today, we are going to review a very important topic, which is the neurological examination. We are going to focus on the important parts of the examination that are related to neurosurgical cases. To start with, let's talk about our goals. Why do we examine patients? First of all, we need to determine that if this patient has a neurological deficit or not. After that, to determine which type of neurological deficit does the patient have. Is it motor deficit, sensory, cranial nerve deficit, or multiple modality deficits? Uh, this will help us in determining the location of the pathology and to try to uh, determine also what is the pathology. Are we dealing with a vascular insult, tumor, abscess, etc.? And is this pathology in any part of the cerebral hemisphere, frontal lobe, temporal lobe, parietal lobe, occipital lobe, etc.? Is it involving the brainstem? Is it involving the cerebellum? Is it involving the spinal cord, spinal nerves, etc.? Parts of a neurological examination that we are going to focus on today are the cranial nerves, motor and sensory examination, deep tendon reflexes, coordination, gait testing, and after that, try to uh, discuss some cases. Now, one of the most common questions by medical students is do we need to examine all patients? And if we need to examine these patients, do we need to do all parts of neurological examination? The answer of this question is at your level as medical students, yes, any patient with neurological symptoms or signs that present to you either in the ER or the outpatient clinic, you should do a full examination. Uh, After that, with experience, you will learn how to do a focused neurological examination. Let's start with the cranial nerve examination. The first cranial nerve to be examined is the olfactory cranial nerve. The function of the olfactory nerve is smelling or olfaction. First of all, uh, make sure that both nostrils are patent. Either you ask the patient to uh, inhale or exhale through his nose while closing one of the nostrils. Then close the patient's eyes and present a small test tube that is filled with a common odor like coffee to the open nostrils. It's preferred not to present an irritant uh, odor like alcohol, for example. Ideally, the patient should be able to correctly identify the odor at approximately 10 centimeters. The second cranial nerve is the optic nerve, which carries multiple functions. The first function is the visual acuity. As you all might know, the Snennen chart, which assesses the uh, visual acuity. Uh, the second is fundoscopy. Both visual acuity fundoscopy uh, will be covered in during the ophthalmology course. Uh, Now going next to the visual field. The visual field is a very important part of the examination of the optic nerve. Ideally, the examiner and the patient should uh, be at the same level, separated by approximately 1 meter. You can approximate that by putting your hand on the patient's shoulder at a distance of your arm and the forearm. Each eye should be examined separately. For example, if the patient closes her or his right eye, the examiner should close the left. The examiner should move their hand out towards the periphery of the field of the patient where the eyes are open. Then the examiner finger should be equidistant from both persons, i.e., the finger should be exact. Try to position your finger halfway between you and the patient. The examiner should move his finger, either wiggling the finger or holding a light or a red subject, okay, from peripheral to center, okay, along an imaginary line drawn between the two persons. The patient and the examiner should detect the finger at more or less the same time. After that, the finger is moved to the diagonal corners of the field and moved inwards from each of these directions. Testing is then done starting at a point in front of the closed eyes. The wiggling of the finger is moved towards the open eyes, of course. The same way, examine the other eye and record if there are any visual field defects. Here are some examples. Here are some examples of visual field defects. For example, if the patient has any pathology at number 1 level, so number 1 is affecting the right optic nerve, the patient will have total right eye blindness. If the patient is having a pathology compressing the medial tracts of each eye, the patient will have a bipolar hymenopsia. For example, if the pathology rarely, which happens rarely, affects only the lateral optic tracts of the left eye, this will lead to left nasal hymenopia. At the level of 4, for example, at the optic radiation on the left side, these will include the lateral tracts of the left eye and the medial tracts of the right eye. This will lead to right homonymous hymenopsia. And of course, the 5 on the right side will lead almost the same as with the 4th, but with macular sparing. Going to fundoscopy. Fundoscopy is examination of the uh, optic nerve and surrounding structures using what is called fundoscope. You will learn more about fundoscopy in the ophthalmology course, but what are expected to see during the fundoscopy is what is on your right hand side. Uh, as you can see, there are 2 circles. The first circle is the standard. This is what you see. This is during a panoptic ophthalmoscope, which is kind of magnification of the standard. You can see the uh, bright circle in the center, which represents the optic disc. Emerging from the optic disc are vessels, arteries, and veins, which supply the retina and the optic disc itself. The next part of the examination is the color vision, which is done by the Ishihara chart, which examines the color vision of the patient. Usually it comes with like a small book, contains these shapes. The patient should be able to identify the numbers in these circles. The last part of the examination of the optic nerve is the pupillary light reflex, which examines both the optic and the oculomotor nerve. Ideally, the pupillary reflex examination should be done in a dark room. Ask the patient to look away at a fixed point uh, to eliminate the bias of accommodation. After that, slowly bring your light from lateral to medial, for example, in this picture to the right eye of the patient. Um, this should lead to constriction of both the right and the left pupil. Constriction of the right pupil uh, will cause direct pupillary light reflex, and constriction of the other pupil is called the um, indirect pupillary reflex. On the right hand side, uh, there are three cartoon faces. The first one is where both pupils will constrict in reaction to the pupil directed to the right pupil. In the middle, there is a loss of the indirect pupillar reflex. This will lead to constriction of the right pupil and with no constriction of the left. On the last cartoon picture, it demonstrates that there is loss of direct pupillary light reflex. This will lead to only constriction of the contralateral pupil. The pupillary light reflex has an afferent and an efferent nerves. The afferent with an A is the optic nerve, and the efferent is the oculomotor nerve. The light will the light will cause uh, activation on the ipsilateral side. This will go to the Edinger-Westphal nucleus with the ipsilateral, and it will activate the contralateral Edinger-Westphal nucleus, and this will cause constriction of both pupils. Now we'll go through examining the oculomotor, the trochlear, and the abducent nerve uh, together, as these three cranial nerves are responsible for the movement of the extraocular muscles. First of all, there are 6 extraocular muscles for each eye: superior rectus muscle, inferior rectus muscle, the median and lateral rectus muscles, the superior oblique muscle, and the inferior oblique muscle. All these extraocular muscles are innervated by the oculomotor nerve, except the superior oblique muscle, which is innervated by the trochlear nerve, and the lateral rectus muscle, which is innervated by the abducent nerve. So now how to examine the extraocular muscles. As you can see, if you understand the function of the muscle, easily you can understand how to examine the muscles. For example, when you ask the patient, look into your finger superiorly while positioning your finger in front of the patient, and ask the patient to look upward. This will give you, or this by this you are examining the superior rectus muscle, and the same the same position, direct your finger downward in front of the patient and ask the patient to look uh, into your finger or to your finger without moving his head, and this will by this you are examining the inferior rectus muscle. Now do the what is called, or what is commonly known as the H movements. So if you go to the right of the patient, you are examining the right rectus muscle and the right lateral rectus muscle and the left medial rectus muscle. Then while you are on the right side, the left eye is adducted and the right eye is abducted. And when you move your finger upward while the left eye is abducted, you are examining the inferior oblique muscle. And while the same eye is abducted and you move your finger downward, you are examining the superior rectus muscle. And the same applies to the other eye. So if you move your finger to the left side of the patient while he's not moving his head, you are examining the left abducent nerve, which supplies the left rectus muscle, left lateral rectus muscle, and the right medial rectus muscle. Uh, and while the right eye is adducted, you move your finger upward and downward. This, and by this, you are examining the inferior oblique and the superior oblique muscle. Now, examining the trigeminal nerve. The trigeminal nerve has a motor function, a sensory function, and the autonomic function. So the divisions of the sensory part of the trigeminal nerve are the ophthalmic nerve, the maxillary, and the mandibular. And as you can see on the left-hand side, each zone of these sensory nerves. Now, what are the motor function of the trigeminal nerve? It innervates the muscles of mastication. And these are the temporalis muscle, the masseter muscle, and both lateral and medial pterygoid muscles. Now, as you can see in figures A, B, and C, uh, these are the dermatomes of the three branches of the trigeminal nerve. You examine them with a cotton swab. The figure D is how to examine the corneal reflex. You ask the patient to look straight or away from you, and you touch the cornea. This should lead to blinking of both eyes. The afferent nerve is the trigeminal nerve, the ophthalmic division, and the efferent is the facial nerve. Now, examination of the um, other muscles. The temporalis muscle asks the patient to clench his teeth, and by inspection and palpation of the temporalis muscle, which roughly located above the ear immediately. Now, examination of the masseter muscle, as you can see on the right low hand side of this scan. And the last thing is examination of the lateral and medial pterygoid muscles. Now, the medial pterygoid muscle is responsible for closing of the jaw and the mouth, and the lateral pterygoid is responsible for opening of the mouth. Going now to the examination of the facial nerve. The first function of the facial nerve is supplying or innervating the muscles of the facial expression, which are the fronto-occipitalis muscle, the orbicularis oculi muscle, buccinator muscle, and the orbicularis oris muscle. Now, if you want to examine these muscles, as you should know, first of all, ask the patient to raise his eyebrows to see or to inspect the creases of the forehead, which should be present and almost similar bilaterally. Then ask the patient to close his eyes against the distance, try to open them, then to show you his teeth, and finally to blow his cheeks. The sensory part of the facial nerve is the taste of the anterior two-thirds of the tongue. Now, what I do recommend and recommended by other instructors is while you are in the mouth, try to examine what you can do uh, with the parts of the mouth. For example, just test when you test this smell of the anterior part of the two-thirds of the mouth, also which is done by the facial nerve. Test also the taste of the posterior third of the mouth, which is carried out by the glossopharyngeal nerve, the ninth cranial nerve. Also, when you are there, examine the hypoglossal nerve, as we will discuss later, and the vagus nerve. Now, examining the vestibulocochlear nerve. Mainly, it's done by the Weber-Renai test. The Weber-Renai test, you need to bring a fork, a tuning fork, and start doing the Weber test, and then do the Renai test. So later on, we will discuss how or how to interpret the findings on the Weber-Renai test. So tune your fork, put it where you can see on the vertex of the patient head, and ask the patient to see if uh, the hearing is lateralizing to one side. And what we mean by lateralizing, that he can or she can uh, hear on one side more than the other. If this happens, this means one of the two things. Either there is conduction loss where the hearing is lateralizes, or there is a sensorineural loss on the other side. How you can confirm where is the problem? You complete your test with the Renai test. Tune your fork, put it on the area of the mastoid process where you can see this picture on the left hand side, and stay there until the patient stops hearing the tuning of the fork. After that, immediately place the fork uh, in front of the external auditory meatus. The patient should hear the tuning fork um, at least for 4 seconds after that. Now, how can we interpret the Weber-Renai test? First, as we said, just take a history and crude testing which ear has the hearing problem, and this is done by uh, doing friction with your fingers on both ears while the patient is closing his eye and trying to determine where is the problem. Then perform the Weber test. If there is a conduction deficit, the Weber will lateralize to the affected ear. If there is a sensorineuronal deficit, the Weber will lateralize to the normal ear. After that, perform the Renai test. If there is a conductive deficit, bone conduction, which is done while the fork is on the mastoid bony prominence, will be greater than or equal to the air conduction in the affected ear. If there is a sensorineuronal hearing deficit, the air conduction would be greater than the bone conduction in the affected ear. It might seem a little bit complicated, but if you try to understand their Weber-Renai tests, you will never forget that. And please don't hesitate to ask me or any other instructors if there is any difficulty in understanding this or other part of the lecture. Okay, now going to the glossopharyngeal and the vagus nerve. As I told you before, uh, when you ask the patient to open his mouth to examine the facial nerve, you have an option to complete your examination of the oral cavity while doing that. So, first of all, when you examine the soft palate, you are assessing the glossopharyngeal nerve. Ask the patient to open his mouth, either to protrude or not to protrude the tongue. If you have any problem in visualizing the uvula, just bring a tongue depressor. Try not to disturb your patient by going deep, uh, not to cause a gag reflex. So, and ask the patient after that to say ah, okay, and look at this at the uvula. If the uvula turns to one side, as you can see on the right hand side picture. Uh, this will indicate that the patient is having a left glossopharyngeal nerve uh, problem. Now going to the gag reflex. The efferent nerve is the glossopharyngeal nerve, and the efferent is the vagus nerve. And you can do that, as you all know, by touching the posterior wall of the pharynx while the patient is opening his mouth, and this will cause the gag reflex. You can also do what is called the cough reflex by asking the patient to cough. And the third part of the examination is to bring the patient a little bit of water and to drink that water and assess his swallowing. Spinal accessory nerve examination, as you know, it innervates both the trapezius and the both sternocleidomastoid muscles. Ask the patient to look to the left side. This is carried out by contraction of the right sternocleidomastoid and vice versa, and ask the patient to shrug his shoulders. The last nerve is the hypoglossal nerve. Um, Ask the patient to move his tongue inside his mouth while the mouth is closed. Try to palpate the tip of the tongue. Then ask the patient to open his mouth and protrude his tongue. On the right hand side picture, you can see that the why the patient is protruding his tongue is it is deviated uh, to the left side. This indicates that the left uh, hypoglossal nerve is not functioning. Now going to the motor part of the examination. First of all, always when you're examining the upper or lower limbs, make sure to perform or to ask the patient after taking his permission for full exposure. The ideal exposure of the upper limbs are from the shoulder area, and for the lower limbs either from the umbilical or from the mid-thigh down. Inspect the limbs for any asymmetry of the muscles, any fasciculations, which are simply abnormal involuntary contraction of muscle fibers, any atrophy of muscle groups. For example, if you look at both hands on the left side, you can see that the patient has a left thenar and hypothenar muscle atrophies. And by examining, and also don't ever uh, forget to examine the posterior aspect of both legs. As you can see in the right hand side picture, there are atrophy of the right uh, lower limb muscles. Now, assessing the motor power of the group muscles, uh, it's graded from 0 to 5. Grade 0, there are no movement at all. Grade 1, only a trace of flickering or fasciculations are seen. Grade 2, the movement is possible only when the gravity or the effect of the gravity is eliminated. Grade 3, the patient can move the muscle only against the gravity, and when you apply any resistance, he can't overcome you or that resistance. Grade 4, muscle strength is reduced, but the muscle contraction can move against the gravity and minimal resistance. Grade 5, the muscle contracts normally against full resistance. Now, these are some examples of muscle groups and joint movements that are important when you assess the examination of the upper and the lower limbs. So this is an important table. For example, let's take an example of the arm flexion or the elbow flexion, how you do that. And it's which muscle innervates that, okay, and what's the name of peripheral nerve. This is a very important table. This is also very important, which is a continue of the previous table. Another table for the examination of the lower limbs. Now going to the examination of sensation. So when you examine the body, you should know at least the major dermatomal distribution of the upper limbs, lower limbs, and the trunks from the anterior and posterior, and the perianal area. So you should know all of these dermatomes. Also, these are the important dermatomal distributions in the lower limbs and the perianal area. Next will be a very familiar graph, sorry, not a graph, a picture of the body, including the important dermatomes. So this is a very um, familiar uh, picture of the anterior view of the human body, the posterior and the lateral view. So as we can see that, for example, if we look anteriorly, we know that the C6 dermatome will supply the lateral part of the arm, forearm, the thumb, and the index finger. For example, the L4 dermatome will supply the medial malleolus, and etc. Going now to deep tendon reflexes. The first is the biceps reflex, which is innervated by the C5 and C6, mainly C5. You will find variations in the references that you go back and read from. So there are few maneuvers how to examine the biceps reflex. The first one is first of all to determine where is the tendon of the biceps muscle. After that, you tap with your hammer, either while the extremity of the patient is on his thigh or while you hold his upper extremity, and by tapping on the biceps tendon reflex, on the biceps tendon, sorry. Now regarding the brachioradialis deep tendon reflex, as you can see in the image, uh, you wanna hit with the flat surface of the hammer uh, while the arm is relaxed around 90 degrees, and hit the hammer around 10 centimeters proximal to the styloid process of the radial bone. Now going to the triceps deep tendon reflex, as you can see on the picture on the left hand side, you can easily determine the uh, tendon of the triceps, which is located just above the elbow. If you can't feel it, just ask the patient to contract the triceps by stretching the elbow, and easily you can palpate the tendon. As you can see in the other pictures, just tap with the flat side of the deep of the hammer onto on that area, while the arm and the forearm are relaxed. The ankle or the Achilles deep tendon reflex is one of the easiest deep tendon reflex to do. It's easily palpated. You just tap with the hammer while the patient is supine or while he's sitting. The idea here is to grab the foot with the other hand, do minimal dorsiflexion, so you can feel the plantar flexion as a reflex after hitting the tendon. Now we are going to talk about special reflexes. To start with the Babinski response, which is an upper motor neuron sign. Now, the idea behind the Babinski reflex is to scratch the plantar aspect of the foot, as you can see on the left-hand side picture. Scratch from outer to inner side or from lateral to medial side, going over the arrow that is demonstrated. This should be done over 5 to 6 seconds. Avoid doing that quickly. A positive reflex will show uh, mainly extension of the big toe, as you can see. This might be associated with fanning of the other toes. Now we are going to talk about coordination or the cerebellar signs. The first part of the coordination examination is the finger to nose testing. As you can see, the examiner is on the right side. Ask the patient to touch the tip of his or her nose and then go back and touch the tip of your finger. Move your finger around superiorly, inferiorly, to the right and to the left, and assess the patient's coordination. The other part of examination of the coordination is the alternating hand movements. Ask the patient to alternate rapidly for each hand in supination and pronation, and examine each hand apart. So the last part of examination uh, for coordination and for proprioception also is heel to shin testing. Ask the patient to put the heel on the knee and run it down on the anterior uh, part of the shin all over down to the ankle. Ask him to do that repeatedly and examine uh, each leg apart.